Now, this induction of labor is not a new topic for you at all because you are almost towards the, the later part of the obstetrics discussion, and you know which are the drugs you give for the induction of labor and what is the meaning. So let's combine all of those knowledges which we have gained before in this topic. This is a very short topic. Now, the meaning of induction of labor is stimulation of uterine contraction with intent to cause vaginal delivery prior to the spontaneous onset of labor. So what does that mean? Till now, okay, till now, the labor has not started. The uterine contraction has not started, but still we stimulate that uterine contraction by giving certain medicine or by doing certain procedure so that vaginal delivery can occur in time. This is known as induction of labor. So let's repeat again. Stimulation of uterine contraction with intent to cause vaginal delivery prior to the spontaneous onset of labor is called induction of labor. And we don't do this all the time. Now, there are certain indications for this. For example, okay, uh, the lady has already crossed 40 weeks of gestation. The given time, the date is already crossed. Still, there is no, start of the labor pain. Now, we cannot wait more longer there. So we have to induce the labor. This is one, example I'm providing. Another one, some of the lady may present to the hospital with intrauterine fetal death. So how to take that fetus outside? By inducing the labor. That is another example you can think of. Cervical ripening is an important term which is associated with induction of the labor. So the meaning is it is the softening, thinning, and dilation of the cervix to facilitate successful induction of the labor. So the same drug or the same procedure which we use for induction of the labor will also do softening of the cervix or ripening of the cervix. Okay, so when we move on to the topic, you understand clearly what I mean here. Now, what are the indications of induction of the labor? Please pay attention here. These are the indications. These are risk to the mother or fetus of continuing pregnancy, and these risks outweigh the risk of delivery and no contraindication to the vaginal birth. So this is a little bit, given in a complicated fashion, but let me clarify this easy statement for you. If we continue the pregnancy, the risks to the mother and fetus should be higher than the risk of delivery. Then only we induce. Remember that. If the risk is not higher to continue the pregnancy, then why to induce the labor? Okay, so this is the first thing. And second, during the induction of labor, we always perform vaginal delivery. So there should not be any contraindication to the vaginal birth. One small example I can provide you here. In grade 3 or grade 4 placenta previa, you don't induce the labor because vaginal delivery is not possible there. So that induction of the labor may be very harmful in that condition. Okay, so all these indications should be fulfilled. Another point, labor should not be electively induced prior to 39 weeks of gestation due to significantly elevated neonatal morbidity. We don't induce usually prior to 39 weeks of gestation. The usual condition is near to the given time. You call it expected date of delivery, isn't it? It is exactly at the 40 week, right? So till that time, if there is no labor pain start, then we induce the labor. Let's move on. Now, all of you, please pay attention to one of the very important question which you may get in different obstetrics exam. If you pay attention, it is very easy to understand. This is known as Bishop scoring system. Now, what is this Bishop scoring system and why we are talking this in connection with induction of the lever. Now see here. This Bishop score or Bishop scoring system has 5 important heading. First, one is dilatation of the cervix. Second, position of the cervix. Third, effacement of the cervix. Fourth, station of the presenting part. And fifth, what is the consistency of the cervix? So once again, what do you mean by consistency? What is consistency? Yes? Anyone? Consistency means how you feel it. What is the feeling? Okay, that is consistency. Don't get confused. It is the feeling. Now, according to this Bishop score, regarding the dilation, okay, see that we give a score 0 for the closed dilation, means it is not yet started. The cervix is closed. 1 is given if cervix is dilated 1 to 2 centimeter. 2 score is given for 3 to 4, and 3 is given for 5 to 6. Or more than that. Position of cervix 0 for posterior, which is most unfavorable position. 1 mid position or at the center, and 2 is anterior cervical position. Okay, so this is the score of 2. Effacement, this is the every student know. What is effacement of the cervix? Still, let me ask this question. Yes.
The effacement is the thinning and the stretching of the cervix, sir.
Exactly. Exactly. This is thinning of the cervix, stretching and thinning of the cervix. Excellent. I'm sure many other students also know this or remember this. So if effacement is only up to 30%, or if it is not effaced at all, we give score of 0. 40 to 50% effacement, score of 1. Okay, 6 to 70% score of 2, and 80% effacement has a score of 3. Station, now that also you know, this is the descent of the presenting part in relation to the ischial spine. This is called station. Okay, so 0 is -3, means way above the ischial spine, and when it is plus, it is below the ischial spine. Now no need of an explanation here. And cervical consistency, firm is 0, medium is 1, and soft is 2. So we want softer cervix, then only the chance of induction of labor is higher. Now, after discussing this Bishop scoring system, what is the interpretation? That is important. Okay, so let's talk about the interpretation now. After adding all these score, okay, if a Bishop score of 8 or greater is found, then it is considered to be favorable for induction. That's why we are doing this. So Bishop score of 8 or greater is considered to be favorable for induction of the labor. And that means the chance of a vaginal delivery with induction is similar to the spontaneous labor. So if anybody asks you this question, why you assess the Bishop score, your answer should be this. We calculate Bishop score to know whether there is a successful induction of the labor or not. If score is 8 or greater, then there is a high chance of succession of induction of the labor. A score of 6 or less is considered to be unfavorable if an induction is indicated. Cervical ripening agents may be utilized. Okay, we want to make that cervix ripe first, and then only induction is tried. Let's move on. Now these days, okay, these days they have revised this Bishop score and they have made it simplified Bishop score. Now see this simplified Bishop score, okay, is leaving some of the points behind. Now after going through this table, you can clearly answer what are those points left. So see that dilation is still there, station of the presenting part is still there, and effacement is still there. So which 2 points they have left? The cervical consistency is left and cervical position is left. So in simplified Bishop score, we have only three criteria: dilation of the cervix, station of the presenting part, and cervical effacement. And these are the same type of scoring. Now look at the interpretation here. Total score, and this is a sensitivity and specificity of a successful induction of the labor. If Bishop score is more than 4, or simplified Bishop score, I should say, is more than 4, the sensitivity, okay, is 59.2% and specificity is 67.9 of successful induction of the labor. If it is more than 6, okay, now see there, it is a bit higher. This is 81. Okay, this has to be 81, not 18. This has to be higher than this. So you need to correct it a little bit here. So these days, simplified Bishop score is very commonly used than the complete Bishop score. And one point I like to highlight before we move further: multipara are less likely than primipara to fail the induction or require cesarean delivery at a given Bishop score. Means multipara have a more chance of responding to the induction of labor than primipara. Now let's come to the topic proper. We are just talking about some related information. What are the method of cervical ripening and induction of the labor? Now these are the terms or a thing which you already know, most of them. See this? Oxytocin is probably the most commonly used agent here. Oxytocin. Okay, so this oxytocin will contract the uterus, okay, and start the labor pain or start the process of labor. Misoprostol, this is PGE1 or prostaglandin E1. It can be given for cervical ripening. CR means cervical ripening, or induction of labor as well, both way. And it can be given oral or vaginal. Dinoprostone or PGE2 is another agent we can try here, both for cervical ripening or induction of the labor. And it is usually inserted into the vagina. Amniotomy. What is amniotomy? Yes?
Amniotomy is
Cutting
also
of
known as the artificial rupture
amnion.
of membranes in which the amniotic membrane is ruptured, so the fluid is pushed out, and so which will ultimately cause the induction of labor.
Exactly. Exactly. I'm sure this is a surgical term. I'm sure every student know this. Tomy means it is making an opening there in the amniotic membrane. You just cut that amniotic membrane or rupture that amniotic membrane. Okay, also known as artificial rupture of membrane. This is very commonly done procedure in the hospital for induction of the labor. Now there are few advantages of this. One, it starts the process of labor, and second, you can see what is the color of the amniotic fluid there. If it is a clear color, like just like a water, you are not concerned at all. But if it is meconium stained, the fetus is in distress there. Okay, and you need to hurry for the delivery. Another is inserting a balloon catheter inside the cervix. This is balloon catheter mechanism. It is used for both cervical ripening as well as induction of the labor. And another way is a membrane stripping. Now, what does that mean? This is a manual detachment of inferior pole of fetal membrane during the vaginal exam. You just sweep the membrane with the help of a finger. This is called membrane stripping. It will definitely help the release of some prostaglandins there, okay, which will cause cervical ripening. Okay, so let's move further. So these are the information which I like to provide here. Very important question, especially in Viva exam. You love to ask this. What are the methods of cervical ripening and induction of the labor? This is the way you answer. Now, some of the picture here. See this. This is known as artificial rupture of membrane. So there is an instrument which is available there. You just insert it, okay, with the help of the digital examination, and then catch the amniotic membrane and rupture it. This is called artificial rupture of the membrane. Very commonly done in the hospital. This is known as balloon catheter, which is inserted into the cervix. And this is the prostaglandin gel, which is inserted there. So all of these are different way. So see there, this is artificial rupture of the membrane. Cervix needs to be dilated at least 1.5 to 2 centimeter just to allow, okay, the instrument to be inserted inside, and then it will catch the amniotic membrane and rupture it. So the important points are usually cephalic presentation should be there, and then there should be no umbilical cord. If umbilical cord is palpated there, we should not go for artificial rupture of membrane. Now, what is the danger? All the amniotic fluid will be drained, and that umbilical cord might be compressed by the presenting part. So don't go for artificial rupture of membrane in that situation. This is known as stripping of the membrane with the help of a finger. So just strip the membrane from the presenting part. Okay, it will increase the process of the labor. So this is also considered a part of induction of the labor. This is called catheter. Okay, a balloon catheter, which is uh, kept there, which is distended there, and it will help the ripening of the cervix. See there. So this is the even the better diagram. Uh, you can insert some of the normal saline here. Okay, this is called extra amniotic saline, which is pushed up through these catheter, and the balloon is also distended with fluid. So both of them will help the process of the labor or help in the induction of the labor. Now, finally, what are the complications of induction? Yes, we have done that, right? So what are the monitoring we need to do? What complication can cause by this induction process? So let's talk about it. Tachysystole is one of the important complication which can occur there, and the meaning is greater than 5 contractions in 10 minutes duration. Greater than 5 contraction in 10 minutes duration. Remember, the normal is 2 to 3 contraction. But if greater than 5 contraction occur in 10 minutes, this is known as tachysystole. This is way too much uterine contraction, and this may be damaging for the fetus which is inside. So the treatment is stop or decrease the uterine stimulation by those drugs. So I'll stop those drugs if I are using it, like prostaglandin or oxytocin, and consider tocolysis. Okay, means opposite of the thing which you are doing here. Just relax the uterus by giving tocolytic agent to tackle tachysystole. Another complication is uterine tetany. Now, tetany means prolonged spasm. So see that contraction lasting greater than 2 minutes means each of the contraction lasting way longer than the normal. Again, there may be certain damage done to the baby. So stop the medicine which you are giving or decrease the uterine stimulation and consider tocolysis. Same type of management. Another important complication may be cord prolapse. It is strongly associated with amniotomy or artificial rupture of the membrane. And if cord prolapse, only one option is left with you, that is cesarean delivery. Okay, don't neglect it. Don't do all those procedures which you have learned before, like knee, chest, chest position or something like that. These are not helpful here. As quickly as possible, the baby must be delivered. And another not very important complication is hyponatremia with extended infusion of oxytocin, because the fluid which you are giving, okay, may dilute the amount of sodium there. In that situation, stop oxytocin infusion along with the IV fluid and consider free water restriction. Consider the restriction of the water, or give only 2/3 of the maintenance fluid to tackle the complication of hyponatremia. So these are some of the important complications of induction. Okay, but let me repeat some of the important points here. Induction of the labor may be necessary in some of the situations, especially when there is no start of the uterine contraction or the labor pain, even after the expected date of delivery, then only we think about the situation. It is never done in preterm, you know, uh, for example, before 37 week. Never done. Okay. So these are some of the important points.